നാച്ചുറലായിട്ട് സംസാരിക്കുമ്പോൾ ഇടയ്ക്ക് അങ്ങനെ ഭാഷകൾ മാറുന്നതിൽ പ്രോബ്ലം ഇല്ലാന്ന് വിചാരിക്കട്ടെ.
First slide. The last slide on data. Slideshow. First slide it look like slideshow to the last slide.
നെറ്റ് സ്ലോ ആണോ അറിയില്ല, ഒരു മിനിറ്റ്.
അതെ അല്ലേ? ഇത് 5th slide ആണ്.
സ്ക്രീൻ ഷെയർ ചെയ്യാൻ ബുദ്ധിമുട്ടുണ്ട്.
താഴെ ഉണ്ടല്ലോ സ്ക്രീൻ ഷെയർ ഓപ്ഷൻ, ഏറ്റവും താഴെ.
ഷെയർ ആയി, പക്ഷെ അത് കേഴ്സർ മൂവ് ചെയ്യണില്ല.
അത് മൊബൈൽ സ്റ്റക്ക് അല്ല, ലാപ്ടോപ്പ് സ്റ്റക്ക് ആയത്.
Sorry for
താങ്ക് യു ഓൾ പേഷ്യൻ്റ് ആയിട്ട് കേട്ടതിന്, വെയിറ്റ് ചെയ്തതിന്. ഇതില് my topic today is a reminder about ARI, seizures and ADD in children. Already Dr. Salima പറഞ്ഞതുമാതിരി പെരിഫറീസിലും അതുപോലെ കാഷ്വാലിറ്റി മെഡിക്കൽ ഓഫീസേഴ്സും മറ്റു കൊളീഗ്സും ഇടയ്ക്കിടയ്ക്ക് വിളിച്ച് സംസാരിക്കാറുള്ള ടോപ്പിക്കുകൾ ഈ 3 തന്നെയാണ്. ഇതിനെക്കുറിച്ചാണ് മാക്സിമം ഡിസ്കഷൻസ് ഉണ്ടാവാറ്. ഒരു മിനിറ്റ്, there is some other problem here. No, I'm sorry. ഇത് ഒരു എറർ ഉണ്ട് ഇതിലേക്ക്. I'm sorry. Topics ARI, ADD and seizures that we had studied in our curriculum and that we are putting to use in day-to-day practice. Discussing about what's in practice and what would be a practical approach to common pediatric cases coming under these 3 categories of diseases, and that too in a primary care facility, in an accident and emergency department, and also in hospitals with facilities for IP. And also another aim of the session is to share any relevant updates, good to know for practice inside the hospital and in your office practice. The first section is about ARI. So about the ARI disease burden, it's the leading cause of mortality in children worldwide, and India accounts for 20% of those deaths. And in states like Uttar Pradesh or Madhya Pradesh, around 500 out of 1,000 children would have had an event of ARI, as against less than 150 out of 1,000 children in Kerala and Tamil Nadu, as given in a study in 2015. Why is it imperative to mitigate the challenge of pneumonia? India has today the largest population of children less than 14 years of age, and it is necessary to address the issue of ARI in children to enable these children to have a healthy and productive life.
Hindu,
Yes.
slide കാണുന്നില്ല.
അതില് ക്ലിയർ ആയിട്ട് കാണുന്നുണ്ട്. തീരെ കാണുന്നില്ല.
ഇല്ല ഇല്ല.
Let me try again. ഇപ്പൊ കാണാമോ? ഹലോ, എക്സ്ക്യൂസ് മീ, ഇപ്പൊ കാണാമോ?
ഇല്ല, സ്ലൈഡ് മൂവ്
ഇല്ല
ചെയ്യുന്നില്ല.
മാഡം.
സ്ക്രീൻ കാണാം, പക്ഷേ സ്ലൈഡ് മൂവ് ചെയ്യുന്നില്ല.
Yeah. Where is this happening? Can we move to the fourth slide?
Yes, yes.
Okay, it is the leading cause of mortality in children worldwide, and India accounts for 20% of those deaths due to pneumonia. In states like Uttar Pradesh and Madhya Pradesh, around 500 out of 1,000 children would have an event in of pneumonia, as against less than 150 in Kerala. Okay, next slide. So why is it imperative to mitigate the challenge of pneumonia? Because India has the largest under 14 population, and this proper addressing of the issue of pneumonia would enable these children to have a healthy and productive life. Yes, please. Next slide, please. Sixth slide. Yes. About the sixth slide. Can I have the sixth slide, please? It's the National ARI Control Program was started in 1990, and it for the first time introduced scientific protocols for the case management in pneumonia and for reducing mortality in under 5 children. The crux of the program is to identify children with ARI at community level by training field workers to recognize identifiable signs and early referral of such cases to higher centers. This was initially started in 1992 as a part of the Child Safety and Safe Motherhood Program. Later, it was merged along with the Reproductive and Child Health Program, and has ever since had many variations of the program. Up till now, it has been practically applied along with the RMNCH, or the Reproductive Mother Neonatal Child Health, along with adolescent, that program, and the IMNCI, which is a comprehensive system for management of measles, sepsis, pneumonia, diarrhea, and malnutrition in under 5 children. The ARI control program applies 3 steps according to the WHO protocol. It is about the case finding and assessment, case classification, and applying the appropriate therapy. So in the ARI control program, the onus is on the cases of pneumonia. Of all the acute lower respiratory tract infections, the chief cause of mortality in children below 5 years of age is pneumonia. And 50 to 60% of these are bacterial. And there are various other agents like the viral organisms, the tuberculosis organism, chlamydia, etc. Haemophilus influenzae, Streptococcus pneumoniae, Staphylococci are the most common ones, and they are still sensitive to amoxicillin, cotrimoxazole, and IV antibiotics. Judicious use of antibiotics can prevent death due to pneumonia. The most common risk factors for pneumonia are the three important factors that alter any pediatric disease, and most commonly discussed issue in pediatric diseases, that is malnutrition, incomplete immunization, and of course in exposure to indoor air pollution. Exposure to indoor air pollution is a hitherto lesser recognized cause of pneumonia, and it is a major factor that contributes to morbidity in pneumonia. WHO criteria for diagnosis of pneumonia, we categorize a case of fever and cough into three categories. The three categories are no pneumonia, pneumonia, and severe pneumonia. No pneumonia is what we frequently see in the OP department, upper respiratory tract infections, where the kid has no fast breathing, no suprasternal, intercostal, or subcostal retractions or chest indrawing, and the baby feeds normally, and the SpO2 will be normal. The diagnosis of pneumonia is to be made when the child has fast breathing and chest indrawing. The fast breathing and chest indrawing points are the PEG items or the core items that are discussed in the WHO protocol for identifying pneumonia. Fast breathing and chest indrawing are sure signs to be diagnosed as pneumonia. The child may have feeding difficulties, but the SpO2 is still normal. In the cases of severe pneumonia, the child has fast breathing, there is severe chest indrawing, the baby is probably unable to feed, or the child is unable to feed, and the oxygen saturation values are not maintained. So what constitutes fast breathing? If a single slide is to be pointed out as an important part of ARI control program, this would be it. For a child less than 2 months, the respiratory rate of more than 60 per minute is fast breathing. For a child aged between 2 months to 12 years, the respiratory rate is 50 per minute, above which it is considered as fast breathing. Age between 12 months to 5 years, if the respiratory rate is above 40 per minute, the child is said to have fast breathing. Now, there is a wide range between 12 months to 5 years. So if you have a 4-year-old child who has a respiratory rate of 36, it is still alarming. So how do you count the respiratory rate? You have to have the baby in a calm position, preferably breastfeeding. You remove the clothing on the chest and put your hand on the chest and count for 1 full minute. 1 full counted minute respiratory rate is what is taken to assess fast breathing. So what are the danger signs in a child with cough? In the OP department or in the emergency department, if the child presents with drowsiness or lethargy, and there is decreased feeding, there is fast breathing, or there is respiratory distress with not maintained, oxygen saturation is not maintained, or there is central cyanosis, or there is a grunt heard, please be aware that these are signs of severe pneumonia, and you cannot send the child back home on oral medications. For a recent case that happened, a few of these issues were there in the child, but for that particular child, in that particular issue, for a 4-year-old child, a weight of 3 kg is a big red flag. I hope you know the case I'm talking about. It was a recent issue that had happened in the tribal area. The case had caught media attention in as a mismanagement case and all. The child having associated malnutrition, severe malnutrition, any of these factors, even a single factor would be important and warrant IP care. So if the patient in front of you is less than 2 months, there are other things that we pay attention to. We ask the mother if there is poor feeding or increased sleepiness, or if there is a fever, and if the baby has any unusually distended abdomen. When you examine the baby, look for fast breathing. Again, look for fast breathing, chest indrawing. Look if there is central cyanosis or grunt, if there is a stridor or wheeze, if there is any apneic spells happening, and look for fever, but also look for hypothermia. The baby less than 2 months may be actually having hypothermia and not respond to the infection with fever. So we diagnose pneumonia under the ARI control program into 3 categories, as we said: upper respiratory tract infection or no pneumonia, which just requires symptomatic management at home. You can you may give home-based decoctions for cough. Send a child home with antipyretics, antihistaminics, decongestants, or nasal drops, and ask them to review in 3 days. If you have made a diagnosis of pneumonia based on the presence of fast breathing and chest indrawing, again, the treatment can be home-based with the clear explanation of the danger signs, as we had just talked about, and the antibiotic of choice is amoxicillin. Earlier, the ARI control program, when it was launched, the core of the program was applying cotrimoxazole in cases of cases diagnosed with pneumonia. But now we prefer amoxicillin, and the dose is 40 to 50 milligram per kilogram per day in 2 to 3 divided doses. Now this is, if we note, it is a higher dose than the regular doses of amoxicillin that we give. ARI control, in the ARI control program, severe pneumonia is managed as a facility-based care or inpatient, and we use IV antibiotics. And if required, we give oxygen and intravenous fluid supports. The medications used usually are IV penicillin G at a dose of 50,000 international units per kilogram per dose, 6th hourly after a test dose. Alternatively, we can use IV ampicillin at 50 milligram per kilogram per dose, 6th hourly, or IV cefotaxime at 50 milligram per kilogram per dose, 8th hourly after test dose, along with IV gentamicin at 5 to 7.5 milligram per kilogram IV once daily. You can also use equally effective or IV ceftriaxone or injection coamoxiclav, but for all practical purposes, injection ampicillin with gentamicin or injection cefotaxime with gentamicin is preferred. The most important factor in prevention of pneumonia, case load, to reduce case load in the community, one has to stress on the management of malnutrition and also address the issue of immunization. Partial immunization cases are very frequent, and a measles vaccination, a Hib vaccination, and a pneumococcal vaccination will go a long way to protect the child from the morbidity of and incidence of pneumonia. Now, measles vaccine is very important. Actually, in our area in Kuttiyadi, Nadapuram, Perambra, we have a significant outbreak of measles right now, which is being contained successfully thanks to the work of the Public Health Department and the department in Kozhikode. The pneumonia is a serious complication of measles. So if we can reduce the incidence of measles, the incidence of pneumonia will also reduce. It is a live attenuated vaccine with a dose of 0.5 ml given subcutaneously at the 9th month. Hib or Haemophilus influenza B vaccine is again a very important vaccine. It prevents meningitis and pneumonia and is very important in developing countries. And it is being given as pentavalent vaccine as a combined preparation with DPT, diphtheria, pertussis, tetanus, and hepatitis B. And it is given as 4 doses at 6 weeks, 10 weeks, 14 weeks, and a boost at 12 to 18 months. And the third one is a pneumococcal vaccine, which has also been recently added to the immunization schedule in government sector. And we have the conjugate vaccine in our schedule in the government sector. And again, it prevents pneumococcal infections, pneumococcal pneumonia, and meningitis. And it's also effective against otitis media. Again, 0.5 ml intramuscular dose is given at 6, 10, and 14 weeks. And the importance of immunization is so much in the control of pneumonia that it cannot be stressed anymore. We can next go on to the section on ADD. Again, about the disease burden regarding ADD, there are annually 2 million deaths occurring globally, and it accounts for 20% of the under 5 deaths. ADD accounts for 20% of the under 5 deaths. And it is the forerunner of malnutrition in children. And it sets in the vicious cycle of malnutrition and disease burden recurrently once the ADD happens. The cause of death in ADD is dehydration, and the electrolyte and acid imbalances that set in actually lead to a difficulty in managing ADD if we do not pick up the case load from the community at an earlier stage. Next slide, please. The commonest organisms causing ADD, the most common are rotavirus, for which we have included a vaccine in the schedule. There is enterotoxigenic E. coli, which causes another 20%, cholera, Shigella, and Salmonella, and also enteroinvasive E. coli and enterohemorrhagic E. coli are also causes. Some other cases of ADD are caused by Entamoeba histolytica, Giardia lamblia, Candida albicans, and Clostridium difficile. But the most common ones are rotavirus and enterotoxigenic E. coli. So what is diarrhea? Diarrhea is a change in consistency, liquid or watery, and frequency of stools. Consistency and frequency of stools change. Consistency can be liquid or watery, and the frequency of stool is more than 3 times per day. Associated blood in stools would be called dysentery, and 5 to 15% of cases of diarrhea can go on to have persistent diarrhea, which is what we term it when the diarrhea persists more than 2 weeks. There is a socioeconomic angle to acute diarrheal diseases, and people living in poor socioeconomic conditions have poor sanitation. They probably have poor hygiene, personal hygiene, and the non-availability of safe potable water, unsafe food practices, the low rates of breastfeeding, the low rates of immunization, and malnutrition in these people causes severe and prolonged episodes of diarrhea. In children, a case of diarrhea is very important because the dehydration sets in quite early as compared to an adult, because 60% of the child's body is water, and the diarrheal loss is from the extracellular fluid. And as the extracellular fluid is lost, so is the sodium in the extracellular fluid, and there will be further movement of water from the extracellular compartment into the intracellular compartment, and it causes a rapid volume shrinkage in the extracellular compartment. There will be large volume losses, and this causes rapid deterioration as compared to an adult. So what are the signs of dehydration? In a child who comes to the OPD with complaints of loose stools, with or without vomiting and fever, please check, please ask the mother, how thirsty is the child? The signs of dehydration, one of them would be that the child is thirsty, the child is irritable, he may be initially consolable, then skin turgor, would decrease slightly because that it prolongs more than 2 seconds. You pinch up part of the skin on the abdomen between your thumb and the second and third finger, raise up to about a half inch and hold and then release. And it is supposed to go back immediately. If it takes more than 2 seconds, you say the skin turgor has decreased. And further on, if untreated, the child becomes more irritable and unconsolable and goes on to develop sunken eyes, a pinched look. The oral cavity becomes dry and the anterior fontanelle, if open, will become depressed. Next slide, please. The untreated cases will go on to have altered sensorium and seizures, abdominal distension due to hypokalemia, and the urination frequency will gradually lessen, and the volume would also decrease, and the acidotic breathing sets in, gradually hypovolemic shock, and thready weak pulse. With the thready weak pulse, prolonged capillary filling time and reduced urine output would herald an ominous situation. So what are the danger signs in ADD? A thready weak pulse, a prolonged capillary filling time, altered sensorium or seizures, acidotic breathing, and decreased urine output are the danger signs in ADD. When you ask the mother for details of the diarrheal episode, please ask if the child has passed urine or how many times the child has passed urine in the last 24 hours. Please don't miss that question. So how do we manage ADD? We categorize into 3, just as we did in the case of ARI. We categorize ADD as a case of ADD with no dehydration, which would go on to plan A, and some dehydration in a case of ADD, we would go on to plan B, and a case of ADD with severe dehydration, we would manage with plan C. So what is plan A? Where the child has diarrheal episodes, but no evidence of dehydration at the point of examination. The assessed fluid volume loss is about 50 ml per kilogram. The child is alert. The eyes are normal. The child drinks normally. He's not too thirsty. The eyes, tongue, and mouth are moist. The skin pinch would go back within 2 seconds. We need a home-based treatment under plan A, and ORS is the cornerstone of this plan. We explain the feeding process to the mother. We ask her to continue breastfeeding if it's a breastfeeding child. We ask her to give home available fluids. We ask her to give a light, energy dense diets, but not thick diets. And most importantly, we explain the danger signals. There is if there is increased stool frequency or stool volume or a blood or an appearance of blood in the stool, or if there is persistent vomiting that prevents retention of the ORS being given, or if the child has intractable fever or abdominal pain, or if the child is simply refusing feeds, ask the mother to come back, or else we could review the case in 2 or 3 days. We have to explain and stress as much as possible that ORS is the cornerstone of managing this thing at home, and if ORS is not possible to be given at home, it would not give a complete or a desirable result in the management of ADD with no dehydration at home. Plan A, again, ORS therapy to prevent dehydration. We give roughly about 500 ml of ORS per day in a child with diarrhea but no dehydration. If the child is less than 2 years of age, 1000 ml of ORS per day if the child is between 2 to 10 years of age, and 2000 ml of ORS if the child is more than 10 years of age. Now, considering that a glass would be approximately 230 to 250 ml of fluid, it would come to 2 glasses of ORS in a day if the child is less than 2 years of age, and similarly for other age groups. if the child has diarrheal episodes and on examination, we are finding features of some dehydration, the assessed fluid loss is 50 to 100 ml per kilogram. And we can note that the child is slightly restless and irritable, but although he's thirsty, he drinks eagerly. He's able to drink and he asks water and he drinks eagerly. The eyes would appear slightly sunken. There is dryness in the oral cavity, and the skin pinch would go back in a slightly longer time than the 2 seconds that we allow for assessment. It is a facility-based management in Plan B, diarrheal episodes with some dehydration, and ORS is started at the earliest. So we calculate the fluid requirement. The total requirement of any child is the normal daily requirement, dehydration deficits to be corrected, and ORS or fluids required for correction of the existing deficit. And the third is maintenance of the ongoing losses. So how do you calculate the daily fluid requirement? So for a child with diarrheal episodes and some dehydration, the daily fluid requirement is calculated as with any other situation. Up to 10 kilogram of the child's weight, the child requires 100 ml per kilogram. From the 10th kilogram to the 20th kilogram, the requirement is 50 ml per kilogram. And more than 20th kg, the requirement is 20 ml per kilogram. So briefly to suggest an example, a 22 kilogram, 7-year-old child who has ADD with some dehydration, the fluid requirement would be 10 into 100 plus 10 into 50 plus 2 into 20. So a requirement of 1540 ml per day. That is the daily fluid requirement, normal daily fluid requirement. The second part is the deficit calculation for the rehydration that has to be instituted, and the deficit calculation is done as 75 ml per kilogram, and the fluid of choice is ORS, and this has to be replenished over 4 hours. So if a 10 kilogram baby has diarrheal episodes with some dehydration, we give 750 ml of ORS. That is approximately 3 glasses of ORS over a period of 4 hours. Cup and spoon or sips from the glasses are suggested. Likewise, for a 15 kilogram child, it would be 15 into 75, and 1125 ml of ORS is needed to be given in around 4 hours. So 5 glasses of ORS is the instruction given to the mother. And the third part of Plan B is fluid therapy. After signs of dehydration subsides, we go on with the ORS administration, and that at 10 ml per kilogram per loose stool till the loose stool subsides. Plan C is applied when the child has diarrheal episodes and has presented to you when he has already developed severe dehydration. And the assessed fluid volume loss at that point of time is 100 ml per kilogram. What we have to note is that the child is probably lethargic with altered sensorium and seizures. The child is not able to drink. He has sunken eyes, dry tongue and mouth, and the skin pinch goes back very slowly. The management of ADD with severe dehydration requires IV fluids and ORS, and the fluids of choice are normal saline, ringer lactate, or isopine. Normal saline is preferred, and we give 100 ml per kilogram over 3 hours. And now this is split, this 100 ml per kilogram over 3 hours, this 100 is split into 30 and 70. And if the child with dehydration is less than 12 months of age, we give this amount of IV fluids over 6 hours and not 3 hours. So the 30 ml per kilogram is given in the first half hour as bolus dose, and the rest of the 70 ml per kilogram of this 100 ml per kg is given in the next 2.5 hours. This in a child less than 12 months would be, as I said, 6 hours in total, 1 hour for 30 ml per kg volume, and 5 hours for the rest of the 70 ml per kg volume. If IV access is not obtained, a nasogastric tube can be inserted or intraosseous access can be established. Please reassess the child every 15 minutes. And for babies less than 2 months of age or less than 5 kilogram in weight, the complications set in early. So early referral is advised. Here, diarrhea is likely an indicator of underlying septicemia or other infections. Called parenteral diarrhea, we have to be aware of this possibility in children less than 2 months of age presenting with diarrhea. A slide about the WHO recommended ORS. It contains 2.6 grams of sodium chloride, 13.5 grams of anhydrous glucose, and 1.5 grams of potassium chloride. And that comes to sodium 75 millimoles, glucose 75 millimoles, potassium 20 millimoles, chloride 65 millimoles, and citrate at 10 millimoles. So what is the diet to be advised in ADD? The first and foremost advice to be given to the mother in a breastfeeding child, continue breastfeeding. You give energy-dense feeds with least bulk or small feeds every 2 to 3 hours. Home available fluids can be continued. Avoid tea and other beverages. You can make khichdis, rice with curd, rice with dal, rice with lentils, or banana with milk, etc. Avoiding high fiber foods as advised. And diet needs some zinc supplementation for a period of 14 days. And it is given at 20 mg per day for children more than 6 months of age. And the preparation is usually 20 mg in 1 ml or 5 ml preparations of zinc, and you give accordingly. More than 6 months of age, you can give 20 mg. Less than 6 months of age, again, it is at 10 mg. Please be wary of abdominal distension and convulsions in a child presenting with diarrhea. If there is a mild distension, please look for the bowel sounds. And in severe distension or in mild distension, if there are absent bowel sounds, suspect paralytic ileus. And this is due to hypokalemia or intake of anti-motility agents, necrotizing enterocolitis, or septicemia. At any rate, it requires assessment at a higher center. So from a peripheral center, please do refer to a higher center. If convulsions occur in a child with ADD, again, it warrants referral to a higher center. It can be due to hypoglycemia. It can be due to associated febrile seizure, may be due to hypo or hypernatremia, hypokalemia. There can be associated intracranial infections, venous or sinus thrombosis. Next, we go on to the third section, seizures in a child. So what is seizure? Those are abnormal, paroxysmal, electrical activity in the brain resulting in motor, sensory, behavioral, or autonomic manifestations. So what are the most common causes of seizures in the newborn period? It is usually birth asphyxia or intracranial trauma or intracranial hemorrhage, hypoglycemia or hypocalcemia, infections, congenital brain malformations, inborn errors of metabolism, and pyridoxine-dependent seizures. Practically, what we would see most commonly is hypoglycemia and birth asphyxia, but we do see cases of hypocalcemia and brain malformations as well. Beyond the newborn period, simple febrile seizures have to be considered when a child presents with seizures. There are other epilepsy syndromes, inborn errors of metabolism, storage disorders, birth asphyxia, trauma sequelae, infections, metabolic causes, including hypoglycemia, intracranial space-occupying lesions, intracranial vascular events, and drugs and poisonings have also to be kept in mind, is also to be kept in mind in a case of child presenting with seizure. What is status epilepticus? It is any seizure that persists for more than 30 minutes or multiple seizures irrespective of duration with no regaining of consciousness in between. Usual duration of a seizure is approximately 5 minutes. So how to manage an episode of seizure in a primary health center or a accident and emergency department? First, focus on the ABC. In the seizing child, lie the child down on a flat surface, loosen his clothes, assess the mouth for any foreign bodies, watch the respiration, check the carotid pulse, and check if the extremities are warm or cold. Start by providing oxygen. Preferably, the child can be shifted to the left lateral position. If there is vomiting happening simultaneously, suction can also be given. Check the GRBS, draw blood for investigations, and we can insert a cannula, check GRBS, draw blood for investigations, one for CBC, one for RBS, one for serum, for the checking of serum calcium, serum electrolytes, LFT and RFT. This can be all done simultaneously. If the GRBS is low, we go according to the protocols for management of hypoglycemia. Next slide, please. So if the child is actively seizing, to terminate the seizure episode, most commonly we prefer IV lorazepam at 0.1 mg per kg, or IV midazolam 0.1 mg per kg, or IV diazepam at 0.3 mg per kg. These are the medicines that I use frequently. Till very recently, we used parenteral diazepam. Parenteral diazepam can be still used at 0.5 mg per kg, or intramuscular midazolam 0.2 mg per kg. These are both useful if you cannot secure an IV access in time. We can repeat this medication after 5 minutes if the seizing continues. Keep checking the vitals. Recently, midazolam nasal sprays have been used. These are actually easily available now, and Medicep and Midas sprays, etc., are all easily available in the market now. These can be bought and stocked in the casualty departments or in the peripheral centers. One or two of the same can be procured. There is ease of administration and ease of calculation for applying. A single meter dose will come to 0.5 mg of midazolam. So we can calculate that for a 12 kilogram child, we give half the number of puffs of weight in kilograms. So if the child is 12 kg, 12 by 2, 6 puffs. So you give 3 puffs in each nostril. This has been actually recommended for even adults, and it's quite effective in children. Now, if the seizure continues in the accident and emergency department, what would you do? We have to give IV phenytoin or fosphenytoin at 20 mg per kilogram, slow IV infusion in 20 ml of normal saline over 10 minutes. You can repeat at 10 milligram per kilogram. So if you cannot set up the normal saline at 20 ml, we can ask a sister if you can spare one to sit down on a chair close to the baby and push in very slowly. If yours is a peripheral center or an accident and emergency department in a hospital where there are no ICU settings, please get ready to shift it to a higher center with an ICU setting. Arrange referral vehicles in the meantime, and keep a set ready for intubation. Instead of IV phenytoin, injection levetiracetam at 60 mg per kg, slow IV infusion in normal saline over 10 minutes is also acceptable. Or injection sodium valproate at 40 mg per kilogram in 20 ml normal saline over 10 minutes is also used. As if the injection phenytoin has not provided the result, the second line of management is administration of injection phenobarbital at 15 mg per kg IV in 20 ml normal saline over 20 minutes. We can repeat the same at 10 mg per kilogram if seizure is persisting, but at this point of time, any interventions further have to be done as management of refractory seizures or status epilepticus, and it is best managed in an ICU with ventilatory support, EEG monitoring, etc. Midazolam infusions, phenobarbital coma, thiopentone, propofol, topiramate, ketamine, etc. are used for this purpose. Briefly about febrile seizures. So very common cases that come to the OP department or in the accident and emergency department. The seizures are associated with high-grade fever, more than 38 degrees Celsius. It occurs in a neurologically healthy child between 6 months to 5 years of age, without any underlying intracranial infection or history of past untriggered seizures. Up to 8% of children within 5 years of age have febrile seizures, and 25 to 40% would have a family history of. The simple febrile seizures are usually generalized seizures, tonic or tonic-clonic, less than 15 minutes. It occurs only once in 24 hours, and it is in a neurologically normal child. Complex febrile seizures, up to 20% are complex febrile seizures. They may have focal signs and symptoms and duration of more than 15 minutes. Recurrent seizures within the same febrile illness episode, and around 2% have the chance of developing epilepsy in the later years. As mentioned before about the management of seizures, if the child is actively seizing in the casualty or in the peripheral center, intravenous midazolam, diazepam, or lorazepam is preferred for seizure termination. And the first episode of febrile seizure needs workup and observation to rule out intracranial infection. So after you have stabilized the case from a peripheral center or in the accident and emergency department, it is better to admit for observation at least for 24 hours. The discharge medications of a case of simple febrile seizure would include febrile seizure prophylaxis. We explain to the mother about febrile seizure prophylaxis. We tell the mother that as soon as the fever starts, start tepid sponging, give oral paracetamol in the recommended dose, and have to keep at least 2 or 3 tablets of clobazam with them, goes by the name Frisium, and 1 mg per kg per day is given as 2 divided doses for the first 3 days of fever. This has to be explained to the mother. Yes. Next slide, please.
Madam.
Yes,
Hello?
okay. Yes, okay. Okay. Yes, that's it. As to wind up my session, I would like to just remind one fact about ARI. That would be if the child comes to you in the OPD or in the accident emergency department with complaints of fever and cough, look for fast breathing and chest indrawing. If the child in the casualty comes with complaints of diarrhea, look for signs of dehydration. And in a case with febrile seizures, please remember that ABCs of managing seizures is as important as the intravenous midazolam, diazepam, or lorazepam that you can give to terminate the seizure. Thank you.
Thank you, Dr. Sindhu. Very well presented. നമ്മുടെ ഇടയ്ക്ക് ഉള്ള ടെക്നിക്കൽ പ്രോബ്ലംസ് അല്ലെങ്കിൽ വളരെ ടോപ്പ് ആയിട്ടുള്ള ഒരു പ്രസന്റേഷൻ ആയിരുന്നു. എല്ലാ ഭാഗവും ടച്ച് ചെയ്തിട്ടുണ്ട്. ആൻഡ് വെരി ഇൻഫർമേറ്റീവ് ഓൾസോ. ക്വസ്റ്റ്യൻസ് ഉണ്ടെങ്കിൽ ഒരു 10 മിനിറ്റ് നമുക്ക് ക്വസ്റ്റ്യൻസിന് ടൈം കൊടുക്കാം. ചാറ്റ് ബോക്സിലൊന്നും കണ്ടില്ല.
Less than 6 months ഒക്കെ ആണെന്നുണ്ടെങ്കിൽ നമ്മൾ ORS എങ്ങനെയാണ് കൊടുക്കേണ്ടത്?
സിന്ധു
സ്ലൈഡ് ഒന്ന് എടുക്കാമോ? ORSന്റെ ADD. Yes. ഏജ് ലെസ് ദാൻ 6 months ആണെങ്കിലും വെയിറ്റ് വൈസ് നോക്കിയിട്ടാണെങ്കിലും പ്ലാൻ എ, പ്ലാൻ ബി, പ്ലാൻ സി എന്നുള്ള രീതിയിൽ തന്നെയാണ് ഇത് കണ്ടിന്യൂ നമ്മൾ പറഞ്ഞു കൊടുക്കേണ്ടത് മദറിന്. അപ്പോൾ ഫ്ലൂയിഡിന്റെ വോളിയം കാൽക്കുലേറ്റ് ചെയ്ത് പ്ലാൻ എയിൽ നോ ഡീഹൈഡ്രേഷനിൽ നമ്മൾ കൊടുക്കുന്ന അളവും കപ്പ് ആൻഡ് സ്പൂൺ യൂസ് ചെയ്ത് കൊടുക്കാം. അല്ലെങ്കിൽ മദറിനോട് അത് മടിയിലിരുത്തിയിട്ട് സ്ലോ ആയിട്ട് കപ്പ് ആൻഡ് സ്പൂൺ യൂസ് ചെയ്ത് കൊടുക്കാൻ പറയാം. ലെസ് ദാൻ 6 months അഗെയിൻ ലൈക്ക് ലെസ് ദാൻ 2 months നമുക്ക് ഒരു ഒബ്സർവേഷനിൽ വെക്കാൻ പറ്റുകയാണെങ്കിൽ നല്ലതായിരിക്കും.
സിന്ധു ചാറ്റ് ബോക്സ്
യൂറിൻ ഔട്ട്പുട്ട് മദറിനോട് മദറിനോട് നോക്കാൻ നമ്മളെങ്ങനെയാണ് പറയാ?
യൂറിൻ പാസ് ചെയ്യുന്നുണ്ടോ എന്നുള്ളത് ശ്രദ്ധിക്കണം. അത് ഒരു എത്ര അളവിൽ പോകുന്നുണ്ട്, സാധാരണ പോകുന്ന അളവിൽ പോകുന്നുണ്ടോ എന്നുള്ളത് നമുക്ക് ചോദിക്കാം. അത് ഡയപ്പർ യൂസ് ചെയ്യുകയാണെങ്കിൽ ബുദ്ധിമുട്ടായിരിക്കും. സ്റ്റിൽ ഒരു ഹെവി ഡയപ്പർ അസസ്മെന്റ് നോക്കാനായിട്ട് അവരോട് പറയാം. യൂറിൻ എത്ര തവണ പാസ് ചെയ്തു എന്നുള്ളത് തന്നെയാണ് ചോദിക്കാറ്. അളവ് സാധാരണ പോകുന്ന അളവ് ഉണ്ടോ എന്നുള്ളത് ചോദിക്കാം. അതിലെന്തെങ്കിലും അവർക്ക് കൃത്യമായൊരു മറുപടി തരാൻ പറ്റിയില്ലെങ്കിലും നമുക്ക് ഒബ്സർവേഷന് വേണ്ടിയിട്ട് വെക്കാമെന്നാണ്. അതിനൊരു പ്രോപ്പർ ഇൻപുട്ട് ഔട്ട്പുട്ട് ചാർട്ട് ഇട്ടിട്ട് അത് വെരിഫൈ ചെയ്യാമെന്നാണ് തോന്നുന്നത്.
സിന്ധു, ചാറ്റ് ബോക്സിൽ ഒരു ക്വസ്റ്റ്യൻ, ഹൗ ടു ഗിവ് PR ഡയസിപ്പാം ആൻഡ് ഹൗ ടു ഡയലൂട്ട്.
പെറക്ടൽ ഡയസിപ്പാം കൊടുക്കുന്ന വെയിറ്റ് ഞാൻ പറഞ്ഞിരുന്നു 0.3 mg/kg ആണ്. അപ്പോൾ ഒരു 10 kg കുട്ടിയാണ് എന്നുണ്ടെങ്കിൽ അപ് ടു 3 mg എടുക്കാൻ പറ്റും. ഡൈല്യൂട്ട് ചെയ്യുന്നത് നോർമൽ സെലയിലാണ്. നമുക്കത് ഡയറക്റ്റ് സിറിഞ്ച് വഴി പെറക്ടലി അത് ഇൻട്രൊഡ്യൂസ് ചെയ്യാം. അതല്ലെങ്കിൽ ഒരു ഇൻഫന്റ് ഫീഡിംഗ് ട്യൂബ് കുറച്ച് ദൂരം ഇൻട്രൊഡ്യൂസ് ചെയ്തിട്ട് അറ്റ്ലീസ്റ്റ് ഒരു 1 inch ഉള്ളിലേക്ക് പോകണം. ആൻഡ് വി ഹോൾഡ് ദ buttocks pinched together for a small amount of time. Most of the time we are also introducing parenteral suppository of paracetamol. So it would be better to send the parenteral diazepam first and follow it up with the paracetamol and pinch the buttocks together.
അടുത്ത ക്വസ്റ്റ്യൻ, probiotics in neonates and children.
Probiotics have been studied very frequently, and final opinion about that from learned people is that there is no role for probiotics. Zinc is the only recommended supplement, and that is given at 20 mg/kg per day for children above 6 months of age. Probiotics have no proven role as such.
Okay, next question, using antihistamines will not decrease the ciliary motility and dry up the secretions. Using antihistamines, will it decrease the ciliary motility and dry up the secretions?
You are asking in relation to ARI, and no, a 2 or 3 day course of antihistaminics wouldn't do much harm.
Tell about KCl therapy in ADD.
What? Please
KCl
repeat.
therapy in ADD. Potassium chloride, maybe.
Potassium chloride. Okay. And that is to be instituted when the child has abdominal distension. So in the case of abdominal distension, where mild abdominal distensions that happen over the course of management of ADD as IP, if you are getting bubble sounds, you can give potassium chloride. It comes as syrup, but for cases of dehydration with possibility of hypokalemia, I usually also get an ultrasonogram done, and oral potassium chloride can be given. I have never actually given it in my hospital setting, and I will have to check the doses.
Next question, febrile seizure prophylaxis, frisium is absolutely needed or midazolam spray SOS is enough for febrile seizure prophylaxis?
That is being recently applied. Febrile seizure prophylaxis, changing over to midazolam nasal spray SOS. Those are some of the recent changes. But for most cases, still febrile seizure prophylaxis with clobazam is being advised because it's easier to procure and keep in stock and administer. Midazolam nasal spray in a hospital setting, when we are doing it, is found to be okay. We are able to apply it correctly. For mothers, unlike just giving a tablet or a syrup, this thing might cause some amount of anxiety in the event of a seizure.
Last question is indication for doing LP in febrile seizure.
Okay, the first episode of febrile seizure, we have to admit the child and observe for 24 hours without giving any sort of anti-epileptics. We do not give clobazam for the admitted period of time and watch if the seizures are recurring. So if the seizures are recurring or the child has a bulging anterior fontanelle or there are investigation findings that are suggestive of any intracranial infections ongoing, then the child probably needs an LP before we give IV antibiotics. So the lumbar puncture is done in such cases. It's not always being practiced in the periphery. We simply keep the child for 24 to 48 hours observation without giving any anti-epileptics and watch if the child has recurring seizures. In the case of recurring seizures, then there is the possibility, again, there is a possibility of intracranial infection. And what we practice in our Taluk hospitals is we refer the case after informing the people in NCH. Lumbar puncture would have to be done.
ARI നമ്മൾ ആംബ്രോക്സോള് അങ്ങനെ ഉപയോഗിക്കാറുണ്ടോ?
Ambroxol is not part of the ARI control program, sir.
റെസിക്ക ഡ്രോട്ട് ഉപയോഗിക്കുന്നുണ്ടോ എന്നൊരു ക്വസ്റ്റ്യൻ കൂടെ ഉണ്ട്. റെസിക്ക ഡോട്ട്.
No, Resica-Drotil also has no role in ADD control program. Zinc is the only supplement given for a case with diarrhea. We could simply give zinc, ORS, and we could explain the danger signs to the mother. If the child has vomiting or fever, we manage that symptomatically. There is no repeated administration of antiemetics as such, just 2 or 3 doses and watch if the child has any further symptoms or dehydration appearing. Reinforcement after a period of time is necessary.
ന്യൂമോണിയയും ന്യൂമോണൈറ്റിസും അങ്ങനെ ഡിഫറൻസ് ഒന്ന് പറയാമോ?
One is probably referring to a viral syndrome. The other one, I think, is part of the discussion in ARI control program. I'm not very sure about the difference.
How long you will use frisium for prophylaxis?
It's not recommended beyond 6 years of age, I think.
എനിക്ക് തോന്നുന്നു ഫീവർ എത്ര ദിവസം വരെ കൊടുക്കണം എന്നായിരിക്കും ചിലപ്പോൾ ഉദ്ദേശിച്ചത്.
In any episode, it is for 3 days. Any febrile episode, we give it for 3 days and withdraw it.
Okay.
ഒരു ക്വസ്റ്റ്യൻ ഉണ്ട്.
Yes, please.
കേരളത്തിലൊക്കെ ഈ ഇതിന്റെ റോട്ടാവൈറൽ ഡയറിയന്റെ മോർട്ടാലിറ്റി ഭയങ്കര കുറവല്ലേ? ഇനി അഥവാ എന്തെങ്കിലും ഒരു ORS വെച്ച് മാനേജ് ചെയ്യാൻ പറ്റിയ ഒരു കേസിനെ എല്ലാ ആൾക്കാർക്കും ഈ വാക്സിൻ കൊടുക്കുന്നതിന്റെ ലോജിക്ക് എന്താ?
മോർട്ടാലിറ്റി കേരളത്തിനകത്തുള്ള കേസ് വെച്ചിട്ട് മാത്രം ജഡ്ജ് ചെയ്യരുത് എന്നൊരു അഭിപ്രായമുണ്ട്. ഓൾ ഓവർ ഇന്ത്യ നമ്മൾ അതിന്റെ കോസറ്റീവ് ഓർഗാനിസം റോട്ടാ വൈറസ്
കേരളത്തിൽ വാക്സിൻ കൊടുക്കണം.
നാഷണൽ പ്രോഗ്രാം അല്ലേ? നമ്മുടെ കേരളത്തിൽ മാത്രം ഒരു ഓൾട്ടറേഷൻ വരുത്തുന്നത് ശരിയുണ്ടോ? അതിന് പോസിബിൾ ആണെന്ന് എനിക്കറിയില്ല.
ഓൾ ഇന്ത്യയിൽ ഇത്ര മോർട്ടാലിറ്റി ഡയറിയൽ ഡിസീസ്
മോസ്റ്റ് കോമൺ കോസസ് റോട്ടാവൈറസ്, അതാണ്. ഓക്കെ,
അതിന് നാട്ടിലുള്ള എല്ലാ കുട്ടികളെ മുഴുവൻ അഥവാ വന്നു കഴിഞ്ഞാൽ അവർ ORS വെച്ച് ട്രീറ്റ് ചെയ്യാൻ പറ്റിയ ഒരു അസുഖത്തിന് എല്ലാ കുട്ടികളെ മുഴുവൻ വാക്സിനേഷൻ ചെയ്യുന്നില്ല. എന്തെങ്കിലും കാര്യമായിട്ടുള്ള ഒരു ലോജിക്കൊക്കെ ഉണ്ടാവും. ഇതൊക്കെ കൊണ്ടാണ് ഈ വാക്സിൻ വിരുദ്ധരൊക്കെ വിരാജിക്കുന്നതാണ് തോന്നുന്നത്. ഇങ്ങനത്തെ ഈ പുതിയത് ഇങ്ങനെ ആഡ് ചെയ്തുകൊണ്ടിരിക്കുന്നുണ്ട്.
It has definitely proven to reduce the mortality and also the morbidity due to ADD. എന്തെങ്കിലും കേസസ് കുറയുന്നുണ്ട്, അത് പ്രൊലോങ് ചെയ്ത് പോകുന്നത് കുറയുന്നുണ്ട്. മറ്റ് ഫാക്ടേഴ്സ് ആന്റി വാക്സേഴ്സ് പറയണതിന് എങ്ങനെയാണ് കൈകാര്യം ചെയ്യണത് അതുപോലെ തന്നെ ഇതും പറയേണ്ടി വരും. ഇപ്പൊ നാഷണൽ പ്രോഗ്രാം എന്ന നിലയ്ക്ക് അത് ഇൻക്ലൂഡ് ചെയ്തതുകൊണ്ട് നമ്മളത് ഫോളോ ചെയ്യുന്നു എന്നുള്ളതിന് കവിഞ്ഞ്
നമുക്കിപ്പോ അതേ
അതിനെപ്പറ്റി
പറ്റൂല.
ആലോചിച്ചിട്ടില്ല.
വേറെ ഓൾട്ടർനേറ്റീവ് ഒന്നുമില്ല. നമുക്കതേ പറയാൻ പറ്റുള്ളൂ. പക്ഷെ എത്രത്തോളം ശരിയാണെന്നതാണ്.
ഒറ്റ ക്വസ്റ്റിനും കൂടെ ലാസ്റ്റ് നമുക്ക് നിർത്താല്ലേ. ഫെബ്രൈൽ സീഷർ ഒരു ഹിസ്റ്ററി ഉണ്ടെങ്കിൽ പിന്നെ ഫീവർ വരുമ്പോഴൊക്കെ കുട്ടിക്ക് കൊടുക്കണോ ഫ്രീസിയം പ്രൊഫൈലാക്സിസ് എന്നാണ് ഒരു ലാസ്റ്റ് ക്വസ്റ്റ്യൻ കണ്ടത്.
ഫെബ്രൈൽ സീഷേഴ്സ് ഉണ്ടെങ്കിൽ ഒരു തവണ ഉണ്ടായിട്ടുണ്ടെങ്കിൽ അപ് ടു 6 years of age ഫെബ്രൈൽ സീഷർ പ്രൊഫൈലാക്സിസ് നമ്മൾ അപ്ലൈ ചെയ്യണമെന്ന് തന്നെയാണ് പറയാറ്. ലോട്ട് ഓഫ് പീപ്പിൾ ഹാവ് ഡിഫറെന്റ് വ്യൂസ് ഓൺ ദാറ്റ്. അഗെയിൻ ജസ്റ്റ് ഇപ്പോൾ റോട്ടാ വൈറസിന്റെ കാര്യം പറഞ്ഞ മാതിരി അഭിപ്രായങ്ങൾ വ്യത്യസ്തമാണ്. ഫെബ്രൈൽ സീഷറിന്റെ കാര്യങ്ങളിൽ എപ്പോഴും പുതിയ ഐഡിയാസ് വരും. ഫീവർ തന്നെ ഇതിൽ ഉണ്ടായിക്കൊള്ളുന്നില്ല. ആന്റി എപ്പിലെപ്റ്റിക്സ് കൊടുക്കുന്നതിനെ പറ്റിയിട്ട് തർക്കമുണ്ട്. പക്ഷേ ഫോർ ഡോക്ടർ സിറ്റിംഗ് ഇൻ എ പെരിഫറൽ സെന്റർ who managed a case of febrile seizure successfully, ആ മദറിന് വീട്ടിലേക്ക് പറഞ്ഞു വിടുമ്പോൾ കൊടുക്കാവുന്ന ഒരു പോസിറ്റീവ് അഡ്വൈസ് അല്ലെങ്കിൽ ഒരു പ്രൊആക്റ്റീവ് ആയിട്ടുള്ള ഒരു അഡ്വൈസ് ഫെബ്രൈൽ സീഷർ പ്രൊഫൈലാക്സിസ് ആണ്. അത് കൃത്യമായി എക്സ്പ്ലെയിൻ ചെയ്ത് കൊടുത്ത് ഇന്നതൊന്ന് ചെയ്യാനുണ്ടെന്ന് അവർക്ക് പറഞ്ഞു കൊടുക്കുന്നത് നമ്മുടെ ഭാഗത്തുനിന്ന് കുറച്ച് സാറ്റിസ്ഫാക്ടറി ആയിട്ടുള്ളൊരു ആക്ഷനാണ്. ഫെബ്രൈൽ സീഷർ പ്രൊഫൈലാക്സിസ് പറഞ്ഞു കൊടുക്കാമെന്ന് തന്നെയാണ് എൻ്റെ അഭിപ്രായം. ഐ സ്റ്റിൽ ഡു.
ഓക്കെ, താങ്ക് യു. ഇനി സംശയങ്ങളൊന്നും ഇല്ലെങ്കിൽ നമുക്ക് വൈൻഡപ്പ് ചെയ്യാം. ഡോക്ടർ നിശാന്ത്,